Sir is ex-consultant physician, cardiologist, Asian Heart Institute and Research Center, Mumbai. Past president of Cardiology Society of India, Mumbai branch. Former head of Department of Medicine and Cardiology Central Railway Headquarters, Mumbai. Different responsibilities in different societies, like past being Indian College of Physicians, past president of Association of Physicians of India, and so on. Along with that, sir is also actively participating in research and actively involved in national as well as international forums in the form of speaker and chairman. Moving on, we'll be having a recap session by Dr. Ashish Nabar, sir. Sir is MBBS MD DNP PhD in cardiac electrophysiology. Sir is consultant cardiologist and electrophysiologist at Jupiter Hospital, Thane and Lilavati Hospital, Mumbai. Visiting consultant at Department of Cardiology in KM Hospital, Mumbai. EC member of Indian Heart Rhythm Society as well as PC member of ISE. First in the country to be awarded PhD in cardiac electrophysiology. Like Dr. S.B. Gupta sir, Dr. Ashish Nabar sir also has enriching experience in the field of cardiology and also involved in publication in national as well as international journals. We'll be having a presentation by Dr. Aparna Jaswal, ma'am. Ma'am is MBBS MD DNP, along with multiple fellowships. Currently, ma'am is Director of Cardiac Pacing and Electrology at Fortis Hospital, Fortis Escorts Heart Institute, New Delhi. Over 2 decades of experience in the field of electrophysiology as well as arrhythmia management and cardiac rhythm disorders. Ma'am is the only resident Indian to have achieved the prestigious CCDS academic teaching and postgraduate training as in national as well as international CMs. So with this, I would like to request Dr. Ashish Nabar sir to start the recap session. Over to you,
So,
sir.
so shall I share my,
Yes, sir.
is it visible?
Yes, sir. Now it is.
Okay, so I'm going to keep this a little short and let the stage, hand over the stage to Dr. Jaswal. Well, let's start with something more simple. Uh, what is the V-paced rhythm here? So this is a pacemaker ECG. Some of you may have difficulty in getting that because you don't see those spikes very easily, and we have these days ECG machines which filter out the spike very well. But believe me, this is an A-sense V-pace rhythm, and instead of seeing your normal kind of a QRS, paced QRS, you're seeing something different. That's a hint. So you are seeing A-sense RV pace. Is it pacing in the apical RV? Is it A-sense RV pace pacing in the outflow? Is it A-sense RV pace pacing in the mid-septal region? Or is it A-sense LV pace? So this is something that you got to tell me. Now, in the interest of the time, I'll take it a little faster. A-sense, I say, because there is no spike preceding the QRS. And if you look carefully, you see some little deflection before the QRS saying that's a paced rhythm. Now, first three options are talking of RV pacing. When you pace the RV, you get a left bundle branch block kind of a rhythm in the lead V1. And if you look at the lead V1 here, it is RBBB type. So definitely it is not RV pacing, which makes it actually extremely simple because you don't have left bundle branch block. It cannot be RV pacing in any form. And therefore it has to be, if the pattern is right bundle branch, there is a LV pace, but some of you will know that you rarely do a A-sense and LV pace only. So usually this will happen. LV will be paced in devices which are called cardiac resynchronization therapy devices or biventricular pacemakers, where you put the one lead in the RV and the other lead is meant to pace the LV, and that is implanted through the coronary sinus into one of its tributaries, and you pace the RV and LV simultaneously to resynchronize the ventricle, and that obviously, because of pacing the ventricle from two sides, tends to activate the ventricle fast, and thus you have a narrow QRS, and you want the LV to be paced actively before the RV to resynchronize, and therefore LV pacing is should be there whenever you implant a CRT, and therefore you should see a right bundle branch block pattern in V1 when you are putting CRT device in some form of the another. There should be a R in V1. So this ECG is actually A-sense by V pace. It cannot be RV pace because there is no left bundle branch block pattern. So this is something that's new, may not be a common knowledge to the physicians looking at ECGs of CRT patients. So this is very important. It can raise your antenna up immediately when you see a right bundle branch block pattern in V1. Let's go to the another ECG, and again you have, let me tell you, a sense V pace as I put it up there. Now this is not difficult because you clearly don't see a spike before the peak, but you definitely see a spike before the QRS. Now let's see what are the options are here. Is it RV apical pacing? Is it RV outflow pacing? Similar kind of options. And is it coronary sinus pacing? Or is it conduction system pacing? So basically, what should use the term enchant you here is the narrowness of the QRS. I mean, many of you have seen the pacemaker ECGs where the right ventricle is paced by putting the lead somewhere in the RV endocardium. It can be apex, it can be mid septum, it can be outflow tract. Now the QRS may differ, but what is uniform in this pacemaker ECGs is that you have a wide QRS. Usually they are 140, 160 milliseconds, and that QRS, LBBB type of a QRS with such a wide QRS immediately tells you that it is some form of RV endocardial pacing. It may be apical pacing or outflow pacing. For the brevity of time, I'll not help you to distinguish that, but left bundle branch block pattern with wide QRS is RV endocardial pacing from somewhere. Now, once again, I said coronary sinus pacing, you don't do in isolation. You don't say A sense and LV pace only. It is usually a part of CRT therapy where you are doing a biventricular pacing. But what you must note here is that you have this narrow QRS with a typical QR pattern in V1, and these spikes are kind of a unipolar pacing spike. So bipolar pacing spikes are small, they may be filtered and not easily seen on the current ECG machines. But the unipolar spikes, when the spikes are big, that's usually unipolar pacing. Now this you do in what is called as conduction system pacing, which is usually in the form of left bundle branch area pacing. How this is achieved is by drilling the lead that you normally use for pacemakers with the help of a sheath support from RV side to just the LV subendocardial region where you are supposed to capture the conduction system, which may be left bundle, left posterior fascicle, left anterior fascicle. Now, when you capture the conduction system, your paced is QRS is going to result from activation of the ventricle through the conduction system. That explains how this becomes almost like a natural and a narrow QRS. Yeah. So this is a new form of pacing. Some of you must learn to identify it, because ask Aparna or me or any electrophysiologist in your hospital, and more of these pacemakers are being implanted. This is the third ECG. Maybe I should have got it first, but we can always learn in whichever way, upside down, downside up, whatever. Pacing induced cardiomyopathy underdiagnosed. Now, this term I hope I introduced in my last talk, but once again, pacing induced cardiomyopathy, this means that because pacing activates the ventricle in a different way, you can have a certain dyssynchrony in the ventricle activation. When the ventricle is activated through the conduction system, that's the most natural and a synchronous way of activating the ventricle. Resultingly, a natural intrinsic QRS is narrow. The- yeah, and when you kind of pace from the pacing lead from the RV endocardium, then you would get the QRS which is broad one, because it paces the muscle, and it's a muscle to muscle cell activation of the ventricle, and then you have a serial activation of the ventricle. So your RV activates first, then the septum, then the LV, and that obviously results in a wide QRS. So now here, what is the pacing site? And now I can help you to decide where it's pacing. That is of some importance, because pacing induced cardiomyopathy, that is LV dysfunction resulting after a pacemaker is induced, a 10% drop in EF or a less than 50% EF, which is new, or sometimes even atrial fibrillation and mitral regurgitation can be included in this definition. So when it's new, when the term pacing induced cardiomyopathy is used, these patients should be watched for any deterioration or symptoms of heart failure. Now, Here, is it
Here
are
is
we
it, are we
apical pacing,
apical
are we
pacing,
mid
are we
septal
mid
pacing,
septal
are we outflow
outflow
pacing, or
pacing,
LV
or
free wall
LV free
pacing?
wall
Now here
pacing?
you
Now
can
here you can
forget the LV
forget
free
the
wall
LV free
pacing
wall pacing,
because that would
because that
result in
would
a right
result in a
bundle
right
branch
bundle
block
branch
pattern.
block
This is
pattern. This is
clearly a left bundle
clearly
branch
a left
block
bundle branch
pattern.
block.
Now these questions
These
are only
questions are
meant
only meant
to
to
help you to
you to
understand the right
understand the
ventricle
right ventricle
activation.
activation.
If you have a
If you have a
negative
negative
concordant pattern
concordant
in V1
pattern
to
V1 to
V6, you have
V6, you
learned
have
from
learned
the
from
VT
the
ECG
VT
reading
ECG
that
that
usually
that
means that the
means
VT is
that the VT is
apical.
apical.
Only when you
Only
have
when you have
activation starting
activation
at the
starting at
apex
the
and moving
apex and
towards the
moving
base,
towards the
can you
base,
get a
can you get
negative
a negative
concordant pattern.
concordant pattern.
If you have a
If you
left
have a left
axis, that is
axis, that is
obviously
obviously
because your
because your
pacing is at
base
the
is at
apex
the
or on the
apex or
little
on
bit
the
on the
little bit on the
septal side.
septal side.
But this
But
usually
this
means
usually
that this
means that
negative
this negative
concordant pattern is
concordant
what you
pattern
should
is what you
should tell you.
should
Plus,
do. Plus,
apex is an
apex is an
inferior
inferior
structure or a
structure or
diaphragmatic structure.
diaphragmatic
The whole
structure. The whole
ventricle is
ventricle is
activated
activated
infra-superior. Therefore,
infra-superior.
you have
Therefore, you
negative
have
QRS
negative
into
QRS
3
into
AVF. So this is RV apical pacing. The RV outflow
the
tract
outflow
pacing
tract
will
pacing
have
will have
positive
positive
complexes in 2,
complexes
3,
in
and
2, 3,
AVF.
and AVF.
That's because the
That's
outflow
the
tract
outflow
is
tract is
situated high up,
situated
and
high
the
up, and the
ventricle, if the
ventricle, if the
activation was to
activation was
start
to
there, would
start there,
activate
would
in a
activate in a
craniocaudal manner.
craniocaudal manner.
So that's
So
how
that's
ECG
how
of RV
ECG of
outflow
RV
tract
outflow
pacing
tract
would be
pacing would be
similarly with the
similar with
LVBB,
LVB,
but with
but
tall
with
QRS
tall
in 2,
QRS
3,
in
and
2, 3.
AVF. Now, this
Now,
form of
this form
pacing,
of
RV
pacing, RV
apical pacing,
apical
has a
pacing, has
20
a
to
20 to
25%
25%
chance of
chance of
causing an
causing an
asymptomatic or
asymptomatic or
symptomatic LV
symptomatic
systolic
systolic
dysfunction called as
dysfunction called as
pacing induced
pacing induced
cardiomyopathy.
cardiomyopathy.
Again, you
Again,
need to
you need
get
to get
familiar with
familiar with
ECG reading,
ECG
normal
reading,
ECG
normal
reading. You should
ECG
not
reading. You should not
mistake it
mistake it
for malfunction or
function
something
or
like
something
that.
like that.
But here,
But
what is
here,
the
what is
ECG
the
showing?
ECG showing?
Now,
Now,
again,
again,
read clear.
read
What you
clear.
can read
What you
here
can read here
clearly is
clearly
these
is
are the
these are the
pacing spikes.
pacing
Sometimes
spikes.
you may not
Sometimes you
see
may
it well,
not
but
see it well, but
most of the times
most
in
of the
almost
times in
all the
almost
leads, you
all the
can
leads you
see
can see
that there is a pacing spike
pacing
which
spike which
precedes the P
precedes the
wave.
P wave.
If the pacing
The
spike
pacing spike
precedes the P
precedes the
wave,
P
you are
wave.
talking of
Talking of
atrial
atrial
pacing.
pacing.
And when would you
And when
pace
would
the
you pace the
atrium?
atrium?
Obviously, when there
Obviously,
is
when
some
there is
form of
some form
sinus
of
node
sinus node
dysfunction. What are the
dysfunction. What
different
are the
types of
different types
sinus
of
node
sinus node
dysfunction? Sinus
dysfunctions? Sinus
bradycardia,
bradycardia,
junctional rhythm,
junctional rhythm,
sinus
sinus
pauses,
pauses,
sometimes
sometimes
tachybrady with
tachybrady
atrial
with atrial
fibrillation
fibrillation,
are some of
are
the
some
forms
of the
of
forms
or
of or
idioventricular or
idioventricular or
rhythmic AV dissociation. These are
dissociation.
some
These are
form of
some
sinus
form of
node
sinus node
dysfunction
dysfunction,
where you put a
where you
dual
put a
chamber
dual chamber
pacemaker with
pacemaker with
predominant work
predominant work
happening by
happening
atrial
by atrial
pacing.
pacing.
Usually, these
Usually,
people
these
will
people
not
will
have
not
AV
have
node
AV node
conduction
conduction
problem.
problem.
Therefore,
Therefore,
once the
once the
P
once the
once the atrial
the
lead
atrial
stimulates
lead
the atrium,
stimulates the
AV
atrium, AV
conduction is
conduction is
normal. The
normal. The
QRS
QRS
resulting is
resulting is
intrinsic. There is no
intrinsic. There
need
is
to
no
pace
need
the
to pace the
ventricle. So,
ventricle.
despite being a dual
Despite being a
chamber
dual chamber
pacemaker, we
pacemaker, we
describe this rhythm as A pace V sense. Sinus node dysfunction. So,
dysfunction.
atrium
So
is
atrium
paced,
is paced
ventricular QRS. QRS is intrinsic because of the
the
normal AV
normal AV
conduction. Very,
conduction.
very
Very,
few
very
people
few
have
people have
AV node conduction
conduction
problems in
problems
sinus
in
node
sinus node
dysfunction, but you should
dysfunction. But you should
kind of be
kind of
sure
be sure
before
before
when you're doing
when
a
you're doing it.
pacemaker in a sinus
Pacemaker,
node
the sinus node
dysfunction, and most
dysfunction,
of
and
them
most of
today
them today
get a dual
get a
chamber
dual chamber
pacemaker.
pacemaker.
So is it a
So is
single
it a
chamber
single
VVR
chamber
pacemaker?
VVR pacemaker?
Not, because if
Because
there is a
if
AV
there is a AV
synchrony on the
synchrony on the
pacemaker
pacemaker
ECG
ECG,
and there is a
and there
pacing
is a
spike
pacing spike
somewhere,
somewhere,
then it
then
cannot
it
be a
cannot
single
be a
chamber
single
pacemaker.
chamber
Obviously
pacemaker.
not
Obviously not
VVIR
VVIR
because there is
because
no
there is no
pacing the
pacing the
ventricle. So you
ventricle. So
cannot
you
pacing in
cannot
the
pacing in
atrium.
the
There has to be
atrium. There has to
atrial
be
lead.
atrial.
We cannot be talking of a
Talking of a
ventricular based single
ventricular-based
chamber
single chamber
pacemaker. Is it a
pacemaker. Is
single
it a
chamber
single chamber
AIR
AIR
pacemaker?
pacemaker?
Well, that is a
That is a
possibility. Some
possibility.
younger
Some
people who
younger
do not
people who
have
do
AV
not have
node
AV
conduction
node
problem,
conduction
you do not
problem, you
want to
do
have
not
too
want
much
to have too
hardware
much
in the
hardware
heart.
in the heart.
You may put a
They put
single
a
chamber
single chamber
atrial based
atrial based
pacemaker because
pacemaker
that is
because
where the
that is where
problem
the
is. AV
problem is.
conduction
AV
is normal.
conduction normal.
This ECG
This
can be
ECG can be
compatible with a
compatible
single
with a
chamber
single
AR
chamber
pacemaker.
AR
Is it
pacemaker. Is it
compatible with a
compatible
dual
with a
chamber
dual chamber
pacemaker?
pacemaker?
Now, just
Now,
because you
just
don't
because you
see
don't
two
see
spikes
two
does not
spikes
mean
does
that it's
not
a
mean that
single
it's a
chamber
single chamber
pacemaker. As I
pacemaker. As
explained
I
just
explained
now,
just
dual chamber
dual chamber
pacemaker
pacemaker
problem is in
problem
the
is in the
sinus node, atrium is there for pace. There is no problem in the AV conduction. Therefore, the intrinsic QRS, there is no need to pace the ventricle. So you know that pacemaker has two functions: sensing function, pacing function. What is happening here is the pacing function is used in the atrium. The AV conduction is normal, the QRS is normal. The sensing function says that there is no need for the ventricular pacing spike to be delivered, and therefore you have A pace, we sense rhythm, very much compatible with a dual chamber pacemaker. Obviously, if you are appearing for any NEET PG or something, you should know that the good answer is D and not one of the B or C. Okay, one more last to go. What must have been the indication for a pacemaker? Now, that's again looking at all these ECGs were about spikes. So one more understanding of the spike. Well, big spikes could be unipolar, but if bipolar pacing is done at a higher output, we can see big spikes, so not necessary. What you can see here is two spikes. What you can read carefully, if you look at lead 3, you can see a pacing spike and a small P wave. So atrium is getting paced. That is for sure. Two spikes, atrial pacing spike is following after say about 130 milliseconds or something like that. Another spike is delivered, which is capturing the ventricle. Now, what is the ventricular capture doing? What kind of a QRS is creating? You have a right bundle branch block pattern in V1, which means that the left ventricle is being paced. Now, when you put a dual chamber pacemaker with the atrial lead and RV lead, the RV lead will give you a left bundle branch block pattern when the RV pacing is happening. This is right bundle branch block pattern. Obviously, the LV is getting paced. Now, once again, what is the axis of this? It is a northwest axis of the QRS, one negative, AVL negative. So the LV is getting paced somewhere in the mid segment or the apical segment, not necessarily basal segment. Also, because of negative paced QRS in V5, V6, you're pacing much down. Now, what is interesting is that this pacing spike is looking a little thick. Unlike the atrial pacing spike, which is very slim, these pacing spike in whichever lead, the ventricular pacing spikes are looking thick, which tells you that there are probably two pacing spikes there, and they are not separated by any great number of milliseconds, and therefore they fall on top of another. The CRT devices or biventricular pacemaker devices have the ability to program AV interval, which in this case is something like 120 or something, and you can even program the VV interval, that is the RV and LV pacing. You can have a difference in milliseconds between them. Usual plan is to pace the LV before the RV, but you can pace them also simultaneously. If it's paced by 40 LV is paced 20 milliseconds early than RV, you may see two spikes. But if they're paced simultaneously, the spike may fall on one another and look thick like this. So that's the reason I brought this ECG. So this is a biventricular pacemaker which is pacing the atrium as well as the ventricle through both the leads, and therefore you have this particular QRS pattern. I think so. What could have been the indication was my question. So complete heart block is possible because the ventricle is being paced. Sinus node dysfunction is possible because the atrium is paced. Both are possible. But what do you think would be the real indication? One doesn't put CRT devices so easily for pure complete heart block or sinus node dysfunction. It is a device which is not put for brady pacing, but it is put for treating heart failure patients because of heart failure with reduced ejection fraction, and particularly if they have a wide QRS in the form of LBPB. So the correct answer in this case would be D. I think I'll stop here, and we are very keen to listen to Dr. Jaswal. Thank you very much.
Thank you, Dr. Ashish, for
I'll
this
unshare
recap.
this.
Thank you. Thank you very much.
Yeah.
Dr. Aparna will take us on the route of channelopathies. So, Dr. Aparna.
Are my slides visible? Am I audible?
Yeah. Yeah.
At the outset, I would like to thank ISC. I would like to thank Dr. S.B. Gupta sir for this opportunity, and of course, Dr. Nava, those are fantastic ECGs. I think moving on to something which is very interesting and the need of the hour, because we've matured as a society where we need to pick up these arrhythmias and treat them adequately. And as Dr. Makar in his message said, that ECGs have been around for 100 years, but there are so many mysteries which we keep unraveling every day on our rounds. And the most important mysteries which give us great enthusiasm are the inherited channelopathies. I don't think that we understand the channelopathies as well. So today is an attempt that all of us learn better, get better on something which is integral. And this is a summary which came out in 2013. I urge all of you who are interested should go through this executive summary, which covers the arrhythmias which I'm going to speak on very well. In the time alive to me, I will make an effort to cover all of these channelopathies to my best. Please remember the focus will be on identification. I shall also briefly touch upon therapeutics of these arrhythmias. Before we begin, it's absolutely important that we understand that the fundamental to every cardiac myocyte is the action potential. It is this action potential that you see here, which has four phases: phase 0, 1, 2, 3, 4. You can also see that this is the phase 0 where there's sodium entry, then sodium entry stops, that's the phase 1. Then there is calcium entry and potassium efflux taking place, which is phase 2 and the plateau. Then we get potassium efflux, which is phase 3. And of course, it goes back into its repolarization phase, which becomes the phase 4. Please understand that every cardiac myocyte is actually a summation of all of these cardiac potentials in an autosomal recessive form. Remember, the action potential of a sinus node is very distinct from the action potential of a ventricular myocardial sac. All of these action potentials, when they happen in cardiac myocytes, are summated. And how are we seeing them? Is by the ECG, which is picked up by the placement of electrodes distant from the heart. Remember, each of these waves is actually a summation of all of these cardiac myocytes, the P wave being the summation of the atrial contraction, the PR being a summation of the activation of the sinus node, then via the Buckman's bundle going from the RA to the LA, activation of the AV node, as well as activation of the His bundle. That is the PR interval, and of course, the QRS being ventricular depolarization, as you can see here, the action potential which I outlined, and of course, the ST segment being the repolarization phase and then the T wave. Now, it's important to understand this because the channelopathies are all happening around this action potential, which I will walk you through. So, if we were to begin with the long QT syndrome, which by far is one amongst the commoner abnormalities that we see in the inherited channelopathies, let me draw your attention that long QT syndrome is a genetic abnormality, which, as you can see on the left, is 1 to 15, where several genes are involved. However, please don't get complex. The most important genes being LQT1, 2, and 3. And as you can clearly see, it's very simple to understand. I showed you in the action potential, the phase 3, there is loss of function of the potassium ions and there is a gain of function of the sodium channels. However, more often than not, in more than 90% of long QT, the abnormality is in the potassium channels, that is the phase 3. Because there is a problem in the phase 3, the potassium channels do not open, as a result of which it results in the prolongation of the QT interval. The long QT can either be autosomal dominant, which is called Romano ward, autosomal recessive, which is Jervell Lang Nielsen with deafness. Please remember, why does Jervell Lang Nielsen come with deafness? Because these potassium channels are present not only in the ventricular myocardial cells but also help in the making of the endolymph in the inner ear. So, a problem or an abnormality of those potassium channels in an autosomal recessive form results in a long QT as well as congenital deafness. And of course, in acquired form, we see it causes syncope, sudden death, seizures, and sudden infant death syndrome. The QT interval, which is most important to be seen, is on long lead 2, lead V5, V6, and if a QTC is more than 480 millisecond, it should make you wakeful that this is a problem area, especially if the patient has had some symptoms. A QTC of more than 440 in men, 450 in women is borderline, is abnormal. The classic arrhythmia is torsa de pointes and macroscopic T wave alternates. There are certain patterns that you see in a long QT, which, if you focus, you should be able to pick out which long QT am I dealing with. Look at long QT1. I told you LQT1 and LQT2 are are because of not opening up of the potassium channels. So what happens here? The QT is prolonged. In LQT1, everything appears normal. But in LQT1, when the patient exercises, normally, what happens when you exercise? Because of adrenergic drive, the QT shortens. But in LQT1, when a patient exercises, the QT does not shorten and can prolong. But normally, if you see, it looks normal proportions. In LQT2, you see a bifid, notched, or a low amplitude T wave. And what do you see in LQT3? Look at the isoelectric ST segment. It becomes very long. I'll give you a little thing to remember here. As we go, we will see again. But remember,
Sorry,
LQT3.
Aparna, just to interrupt you, can you point with your pointer? That will help.
Okay.
You-
Okay. So LQT3, can you see the prolonged ST segment? It's a very simple way to remember. What do you want to remember? You want to remember that LQT3, which is gain of function of sodium channels, typically happens during sleep. Remember, it becomes like a bed. This is the head end of the bed, and this is the bed. So if you see an ECG which looks like a bed, remember it could be LQT3 and it happens typically in sleep. How common is congenital long QT syndrome, which we all wish to know and learn? There was a study which was done and it was concluded it is not so uncommon. For whites, the estimate of long QT syndrome is approximately 1 in 2000. It does not imply that all of these are at risk of sudden death, but it does imply that we must look carefully for long QT syndrome because it is a common occurrence. I told you there are certain correlations between the genotype and phenotype. What are those correlations? So the correlations are this. I told you if you see an LQT1, more often than not, it will happen during exercise. Young children, they can go for swimming or at football, they collapse, it's LQT1. LQT2 typically happens with an auditory stimulus. Can also happen during sleep, but more often has an auditory stimulus. I told you LQT3. Always remember if somebody has a aborted sudden cardiac arrest in sleep, look at the ECG. The ECG will look like this. Long isoelectric segment, head end of the bed. The patient is having problem during sleep. So this is how you understand, am I dealing with LQT1, 2 and 3? Although there are several genes informed, but the most important involvement is of IKS, IKR, and SCN5A, that is the sodium channel gene abnormality. This is how you have genotypical and phenotypical correlation in LQTs. But it's important to understand what is it that predicts the maximum outcome of a patient. It is the ECG phenotype. What does that imply? It implies if the QT is extremely prolonged, more than 499 milliseconds, they are at the highest risk of sudden death. Individuals with a QT of more than 440 are also at risk, but the most important risk factor for long QT syndrome is trying to identify the ECG QTC. Hence, it's important to understand the ECGs. The risk stratification, as given in this, is a very nice understanding that if there is somebody who has had an aborted sudden death, this is the highest risk. Post CPR or spontaneous torsade de peau, it is the highest risk. Then extent of QTC prolongation predicts the risk. I told you, if the QTC is more than 500, it's a very high risk. Then symptoms, arrhythmic syncope or a VT on beta blockers. I will talk to you about beta blockers, in which long QT they act the best. But remember, if you've diagnosed a long QT1, you've given the patient beta blockers, which is the most important drug to be given in an LQT1, and the patient continues to have symptoms, it tells you my patient has a high risk of sudden death. And of course, gene details influence the risk. What gene? The highest risk of death is in LQT3. Remember, LQT3 happens during sleep. LQT3 does not happen because of adrenergic influences. LQT3 will not be influenced with beta blockers. This is the problem, that LQT3 is the highest risk of sudden death. There are certain other settings. In pregnancy, there is no increased risk during pregnancy. However, there is high risk after pregnancy in LQT2. Siblings, remember that when you talk of LQTS and when you take a history of siblings, it is not akin to hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, it is a very strong interplay. In LQTS, it's important, but the interplay is not as strong. The children, high risk in boys, after puberty, higher in women, after age 40, ongoing but diminishing risk, and QTC duration is predictive of risk at all ages. So the whole question arises when you see an LQTS, how am I to manage? I am sure at the end of these slides, you have understood how to diagnose LQT1. It is the exercise which brings out LQT1. It looks normal, the normal proportions of ECG. You make them exercise, they will have symptoms, and the drug here is a beta blocker, which is extremely effective. Nevertheless, if the QT is very prolonged with a very strong history of aborted SCA, you may want to jump on to giving device therapies along with drugs. But remember, when you have LQT3, I told you beta blockers are less certain. Yes, sympathectomy is important. Exercise restriction, we are not 100% sure that if an LQT1 restricts exercise, that he will not have aborted SCD. ICDs in high risk subgroups. A cardiac arrest survivor, syncope on beta blockers, we told you, very early age with syncope, and of course, those who are high risk and asymptomatic, like gerbil Nielsen, they are very low QTC, and of course, males with LQT3. The genotype specific therapies, we have understood LQT1, you must give beta blockade. LQT2, beta blockade may or may not help, but it is known that you could add aldactone. In LQT3, beta blockers will not help. You want to give mexiletine, but remember that it is mexiletine in no way has been studied that it will reduce sudden death in your patients who are at a high risk, as we've already spoken about. I will now show you a case who came just 3 days back. 13-year-old female child admitted with recurrent episodes of syncope. This is a syncope which has been captured by a parent, and I will just show you. That's the reason I don't take a. Yeah. So this is a syncope of this child, which was captured by a parent because this child has had recurrent syncopes, and doctors were thinking that it's a neurological syncope. So this child has become extremely flaccid. I don't want to take you through it all, but you can see the child is having a syncopal spell. When we take the history, which is most important, this child came just recently, I told you. Look at this. These are 5 syncopal spells. The father has taken the history, has outlined it. These are times. Now look at this. On the bed, during sleep, during traveling, and also in school. So this is completely leaves us vexed. Which LQT is this? However, on the bed, sleep is telling me, could it be LQT3? So what is it that you want to see? You suddenly want to open the ECG. This is the ECG of the child. I told you. Look here. When there is prolonged ST segment, it looks like the head end of the bed happening during sleep. Could this be LQT3? But I am also confused a bit because if I look at lead V4, it looks like a bifid. I told you LQT2, you will have bifid waves. So this child is subjected to a genetic study. We have very good genetic studies available now. What did the genetic study tell us? The genetic study revealed that this child has long QT syndrome 2. So you may be interested in knowing what did we do with this child. So since this child was already on a beta blocker, and you can see the child had bradycardic spells, the child had several syncopal spells, it was bordering onto LQT2 and 3. We told the father that the best choice of therapy here would be a defibrillator. But given the age of the child, we also gave the child a choice of a pacemaker and then upping the beta blockers. Please remember, the choice of beta blocker here is nadolol. It is cardio non-selective, and you should want to give nadolol. A young woman who already has an ICD. So look here. She comes with syncopal spell, shocks. What can you see on this ECG? Can you see a polymorphic VT, non-sustained polymorphic VT torsade? Yes. Can you see a short long short sequence? Yes, you can see there is a short, long, short sequencing. Can you see an R-on-T phenomenon? Yes, there is an R coming on the long QT. Can you see an atrial pacing? Yes, because the patient has a dual chamber ICD. So this patient has a long QT, and you can see all of the above here. So remember, QTC of less than 440 is considered normal in both genders. 440 to 450 borderline in men, 440 to 460 is borderline in women. But there are certain questions which I wish to delineate so you can be clear. How to measure and which lead to use? Remember, the proposed leads include long lead 2, any limb lead with the most easily discernible QT interval, and the lead with the longest QT interval. The most important, how to measure the QT interval, especially if the QRS is wide. A wide QRS will lead to an increase in the QT interval that is not clinically relevant. So, what do the electrophysiologists do? We often measure the JT interval, and a JTC of more than 330 is considered abnormal. And how to measure the QT interval in an irregular rhythm. I can share all of this so you can read and learn it again. Measure and calculate the QTC for the QT intervals immediately following the longest and the shortest RR interval on the ECG and average them, because it can be complex. And if a patient is having atrial fibrillation and you're giving drugs, I will show you a case and you will understand why I say that. In a long QT in torsade, the characteristics involved include a polymorphic VT, a QRS morphology, an axis which goes through cyclical. It appears as if it's turning around a point, pre-existing prolonged QT interval, and classically triggered by a long short pattern. Of course, as clinical cardiologists, physicians, we should know and have an eye for acquired long QT syndrome and drugs, ischemia, chronic heart disease, electrolyte abnormalities are the responsible. I will show you the case which I recently saw just 2 days ago, and the treatment is stop the poisons and reverse the reversible. You may have to give no box, no ICD to these patients. Let me walk you through with this case. She is a 72-year-old lady. CAD, ACS, underwent a PCI, had hypokalemia. I want you to focus. She was given a long list of medicines which typically may appear to you very benign and innocuous. Then, this was the ECG that she was discharged with. You can see that there is an intraventricular conduction defect bordering into left bundle, but not a typical left bundle, because according to the Frost criteria, you should have a notch, so it should be more than 120 milliseconds. So, but it's an IVCD going on into incomplete left bundle. Incomplete, we say, because it's not fulfilling the entire criteria. Now, this patient comes back 5 days later with this to the same hospital. Clearly, you can see this patient has developed a long QT, right bundle. Also, there's a right bundle. Also, you can see the patient has developed a 2:1 AV block. You can see, which could actually be a functional 2:1 AV block in the presence of a long QT. But look here, what you thought were innocuous, the patient was sent home on tablet ciprofloxacin, tablet tablet DOM-DT for a sick patient to develop a long QT and present with syncopal spells with these ECGs. So please remember, remove these poisons and your patient will be better. Moving to the next, short QT syndrome, not very often seen, but
I
remember the
think
genes.
just if we take a break here, Aparna, I think just to highlight, it's very important for the audience to know that the QT is measured in the longest QT interval on the
Yes,
ECG. If you have few leads, then take lead 2 and lead V1. But if you
yes.
have a 12 lead ECG, then take the longest QT interval. Easy way of eyeballing is up, of course, if the QT is more than half of the previous RR, that's the most easy way to eyeball. And importantly is you guys as physicians would obviously be dealing with polypharmacy and these kind of a drug-induced long QT, which is less predictable and but most important to pick up whenever you have, because otherwise people will get treated for polymorphic VT with cordron and will these medicines which are, as Aparna says, poisons, they will not be taken off and you will not get a handle on this. Sure. Okay, Aparna.
Thank you. And as Dr. Nabar elucidated, remember, whenever you see a polymorphic VT, do not give amiodarone. Please remember that. The drug of choice would be correction of electrolytes, magnesium, beta blockers if hemodynamic experiment, and xylocard, but not amiodarone. Moving on to short QT syndrome. Short QT, of course, again has genetic abnormalities, but look here, it is a reverse. I told you in long QT, there was loss of function of potassium channels, and here, what are you seeing? There's gain of function of potassium channels, and there is a criteria. If you wish, you can go back and learn this. This is called the Golub's criteria, which is a diagnostic criteria for a short QT syndrome. So if you have a short QT of less than 330 milliseconds, it is diagnostic and has a point score of 3. And you will read this through. I don't want to spend time on this. It's not so common, but you should be well aware that there is a scoring system. This is how an ECG looks like. Clearly, it is complete reverse of what you saw. The QT is so short, and it's because of gain of function of the potassium channels. So remember, when you see something like this with syncope, you should be careful. Moving on to something which I think all of us like to discuss, take it forward, is the Brugada syndrome.
I'll just
let me
interject here, Aparna, for a minute.
Yeah.
It is it's in a humorous way said that there are more people studying short QT than the number of cases of short QT that have been diagnosed in the world. So, jokes apart, but Aparna already stressed that this is very uncommon. It is arrhythmogenic, but it's very uncommon. So, don't get after trying to look for short QT. If once in a while you manage to see something, we should be discussing whether it's really short QT, but this is a rarity to get a short QT.
Absolutely. So moving on to something which we all like to learn, discuss, is Brugada syndrome. So this is a young athlete who comes with syncope early morning. So you see the ECG carefully. Is it type 1 Brugada? Is it a type 2 Brugada? Is it a simple right bundle branch block? Or is it a type 2 Brugada syndrome? So remember, whenever you use the word syndrome, there should be a constellation of signs and symptoms. Just an ECG doesn't become a syndrome. So remember that ECG doesn't become a syndrome. So this is an ECG which is being shared, but this patient has had a symptom. So when a patient has had a syncope, you should be careful. So this is an ECG, and the same athlete presents with syncope during lunchtime. What do you see here? It's completely changed. Now look at lead V1, what it was and what it has become. Remember, the type 1 ECG pattern, which I will discuss in a second, is diagnostic of Brugada. So, it was in the year 1992, the two Brugada brothers saw about 8-9 patients who had a right bundle branch block, had persistent ST elevation, and had sudden cardiac arrest. So, for these patients, they did the post-mortem. They found the heart was absolutely normal. There was no structural abnormality that they could be identified. There was more studies which were done, and subsequently it got the name Brugada syndrome. And we will talk you around. It is described in young, I told you, apparently healthy men. It has many local names, especially in Southeast Asia. It happens often during sleep. It was very fascinating that I was listening to one of the lectures, and it said that in Southeast Asia, and the person giving the lecture was from Southeast Asia, the cardiologist, he said in certain communities where there's a lot of penetration of Brugada and people fear, they tell the young men to wear women's night clothes to sleep because they feel that there are some extra powers which come and take them. So you should remember, Brugada in young men, Southeast Asia, happens during sleep. So what is it that you need to know about Brugada syndrome and Brugada pattern? Remember, type 1 is diagnostic. It's pseudo right bundle branch block. Why is it pseudo? Because look at the R prime. It's so wide. But what is the classic? Is the coved type ST elevation of more than 2 millimeters, followed by negative T waves in the right sided precordial leads, lead V1 and V2. So this is type 1 of type 1, which is diagnostic of Brugada, and we should not miss. Then we have type 2 and type 3 Brugada patterns. Now, what happens here? Clearly, you can see there is a saddlebag deformity in both of them. But here you have a saddle back of 1 or more than 1 millimeter ST elevation and a J point of more than 2. Here you have an ST elevation of less than 1. Whenever you see a type 2 or type 3, you would want to do provocative tests to identify whether you're dealing with Brugada. The most easiest provocative test is to go one space higher and do an ECG. Why do you want to go one space higher? Because the abnormality is in the right ventricular outflow tract, and that's where you can see. And what is the abnormality that you can see? The abnormality is the heterogeneous dispersion between the endocardium and the epicardium, which I told you, if the ECG that you see is nothing but summation of all the action potentials of the cardiac myocytes, the summation of this heterogeneous dispersion is seen on the surface ECG in lead V1. So whenever you have any doubt, tell your ECG grapher, ECG grapher, that take one ECG one space higher and then call the patient back. There are several genes which have been implicated, and of course, SCN5A is one of the most important genes implicated in Brugada syndrome. I told you the most important provocative is go one space higher. Next, you may want to give procainamide infusion and bring out. Look at this. This is without, and this is baseline. One space higher. This is procainamide on the space aligned. And if you go one space higher towards RVOT, what you can see, symptoms predict the has had an aborted SEA, you should give a lot of importance that because that patient is at a very high risk of having a recurrent event. And of course, those who are asymptomatic, you need to follow. You may want to do the patient's provocative tests to identify what happens to the ECG as you follow. This is a very simplistic kind of a guide which allows us to understand what do you want to do when you see a Brugada ECG.
Aparna,
If the
just 1 minute.
patient,
Just a
yeah,
minute. So in these inherited arrhythmia disorders, the attendees would do well to understand that there is a dynamicity in these positive findings. There could be ECGs of a patient with long QT who has a normal QT interval. Similarly, people who have Brugada syndrome at other times may record a completely normal ECG. And that's where this word of provocation comes in, that you bring out that pattern which is diagnostic. So, for example, with long QT syndrome, you can do a provocation by isoprenaline infusion and bring out those long QT, or you record the ECG in the 4th minute of recovery in the exercise test. So, that's the provocation for long QT. And in Brugada, as Dr. Jaswal said, these sodium channel blockers can be used to bring out that Brugada pattern, or positioning the lead in the upper intercostal spaces brings it out. So this is something different than the ECG with structural heart disease, which remains same whichever day you record the ECG.
absolutely. So remember, if somebody has a Brugada ECG, this is the ECG we're talking about, and has had a syncope, then genetics, urgent clinic, and consider a defibrillator. Now, if there's a patient who has had no symptoms, no problem, you just see a type 1, this type 1 ECG, it needs to be given importance. Send the patient to a genetics clinic. And if the genetic clinic, patient has been asymptomatic, but the genetic clinic says that yes, he's got SCN5A gene, now you begin to discuss shared decision making, genetic testing of the family. You need to go here. However, if it is type 2 or type 3, I told you type 2 or type 3, it's important to understand them. If it is saddleback like this and you don't know, very often all of us are in confusional state that is it a Brugada or not? Am I sure this is a Brugada? Then if you have a confusion that is it a Brugada or not, as Dr. Nabar said, first go one space higher, then do provocative tests. But make sure when you do a provocative test, it should be done in a very controlled environment. You should be able to handle it. Get your cardiologist or electrophysiologist friend involved that you want to give procainamide infusion, you want to follow this, you want to do a genetic clinic, and subsequently, supposing you do genetics and still it comes out to be a doubtful, then maybe reassurance is the key. But whenever you see an ECG pattern which raises your suspicion of a Brugada, please remember, do not let it pass by you. Focus. Go one space higher. Talk to the patient, talk to your cardiologist friend, send the ECG, a pseudo right bundle where the R prime is wide, coved, ST elevation with a negative T wave, this should never pass by you. So remember, this is very, very important. Coming to the next, if I may say, is CPVT. The
Aparna, just a
hallmark.
minute.
Yeah.
Would you want to comment on fever-induced
Yes,
Brugada pattern?
yes. So there will be sometimes children, and in fact, the video that I showed you, sometimes patients with fever have syncope. Now, this is a very, very important history that if a patient comes with fever and syncope, do not think it's just a vasovagal simple syncope. Fever in Brugada brings out syncopal spells. Please remember, this is a very, very important history in a Brugada syndrome. In a patient who has fever, the patient can have polymorphic VT, and you need to follow these patients very carefully because that is a hallmark that the patient is having Brugada syndrome. Now, as the name suggests, catecholinergic polymorphic VT. So, what does it imply? Anytime the patient's catecholamines increase, the patient is at risk of polymorphic VT. When do our catecholamines increase? When we exercise. So, like in an LQT1, is most of the times it happens on exercise. CPVT is even more specific to exercise, so much so that sometimes they put them through a stress test to bring out CPVT. It is not as uncommon as short QT. We are seeing more and more cases of CPVT. It is also a genetic abnormality. The genes involved here are the ryanodine receptors or calsequestrin gene, which are responsible, but most often it is the ryanodine receptor gene which is abnormal. The hallmark of CPVT is a bidirectional VT. What is the meaning of bidirectional VT? That every other beat changes at 180 degrees, and that's what is called. I will show you more in the example which comes that it is a bidirectional VT.
Just one
Remember,
second, na, Aparna. You had a beautiful ECG of that bidirectional VT. Now, for the audience, it is important to know that the frontal leads are the ones that bring out the bidirectionality very well, not the precordial leads. So, whenever you have to look for this bidirectional, look in the frontal leads because that's where the bidirectionality of reversing polarity would come out well. Yeah, thanks.
here you can see it. In all of these, you can see it.
Yeah.
So, look at this. So, the problem here is with the ryanodine receptor, with the release of calcium, which happens here, and these channels are responsible for CPVT. Let me take you through this young child. I had seen several years ago. This is a very nice ECG. So, this ECG, what would you think? This ECG is of a child. The parents bring, and you can clearly see that we had put this child on an exercise test. But I'll walk you through this ECG. So you can see there is a P, the PR looks normal, the PR is normal. Look here what's happening. There is these two beats you will call isorhythmic AV dissociation actually. This is a P wave came because of a deep breath. And what happened here? The patient had a junctional escape because this is a non-physiological PR interval. The same thing happened again. The same thing happened again. In fact, the patient is having all along because there is no PR interval, but this ECG doesn't tell you anything. We went through, could it be a long QT? No. Short QT? No. Brugada? No. So you have seen the ECG algorithms, which we just discussed. However, the patient's father came that she's having syncopal spells, especially when she exercises. So we put this child on an exercise, and what do we see? Look here carefully. This child develops a bidirectional VT when we put this child on a treadmill test. So this child has one QRS above and the other QRS looking downward. So this child develops a bidirectional VT. Now, and we could each time we made this child exercise, we could bring about at the peak of exercise, we were able to bring about a bidirectional VT. You can see QRS here, you can see the QRS here. They're absolutely in the opposite poles. So this is what is called bidirectional VT. We put this child for a genetic test and we realized the patient had an abnormality of the ryanodine receptor gene. I told you more than 70% of the time it is because of the ryanodine receptor, and had the phenotype of CPVT1. What did we do for this child? We treated this child with beta blockers. We added the drug of choice here also is flecainide. The patient underwent sympathetic denervation. In fact, I sent this patient to Dr. Yash, Bombay, and it was surgically done. This child underwent, you can see here, this was done in Bombay by the laterothoracic sympathectomy. Surgically, it was done for this child, and this child is doing absolutely fine. We have not had to give her a defibrillator. The way we are following up this child, currently she's in the United States, how we have followed her up is with a stress test. And now her father had a very classic history. Every time she goes to do a bicycle, he gets a call from the guard that he's had a syncope. And he's so happy that we have been able to manage this child with beta blockers, flecainide, and sympathectomy, and she's doing absolutely fine. So remember, CPVT is not that common. There is exercise-related polymorphic VT. You see a bidirectional VT. I showed you a normal baseline ECG. You do an exercise test or IV isoproterenol. Beta blockers, flecainide effective. Sympathectomy effective. Calcium channel blockers are not effective. ICDs are reserved for high risk. If this child had continued to have symptoms despite what we did, we were considering an ICD, but of course can increase the risk of arrhythmic storm. So I've already outlined that the drug of choice here is beta blockers, and class 2A is class 1C drugs. That is, you want to give flecainide, and if the patient continues to remain symptomatic, it is then that you want to go ahead and give ICD. Coming to the last, early repolarization syndrome. Please remember that early repolarization syndrome is more and more being picked up now, but you should look for, you have now understood long QT, you've understood Brugada, short QT, CPVT. Early repolarization syndrome has to be looked out for in non-Brugada ECGs. So the Brugada ECG was lead V1 to V3. For ERS, you should look for non-Brugada ECGs. If there is evidence of J point elevation of more than 1 millimeter in inferior or lateral leads, so that means your right-sided lead V1 to V3 are absolutely normal, but you are seeing that J point elevation of more than 1 in your inferior or lateral leads, the patient has had an aborted SCA. You should look out, is my patient having an early repolarization syndrome? It has also a genetic abnormality. It is common. It is more and more of us are seeing it. We still are not clearly defined as to, if you see an asymptomatic ERS, what am I to do? Yes, you should want to do a genetic if there is a family history, but surely you should not be defibrillator hungry. You should follow up these patients, but have an eye of anybody who comes with an aborted SCA. You look for long QT, you look for Brugada, you look for CPVT. You should also look for ERS to be sure that you're not missing something. A J point elevation of more than 1 millimeter in inferior or lateral leads should make you watchful for that. I think with this, I would like to close. This is my team, and I'm thankful to each one of them for having collected the ECGs for me, scanning them, and putting them all together with all of you. Thank you so much for a patient listening.
This team is more than what Indigo has. This is 70%. Okay. I think wonderful talk, Aparna, very suited to the attendees, starting from the ECG and briefing about therapies and warning about sudden cardiac arrest and taking us to the role of genetic studies. Only briefly is that although Dr. Jaswal showed a number of genes that are incriminated, but she also stressed that in each of these disorders, there are certain that are most common. So LQT 1, 2, 3 genes are most common in LQT. Brugada, SCN5A is the most proven and incriminating gene. In the ERS, in the CPVT, it is CASQ2 and ryanodine RYR2 gene that is most important. So whenever you, of course, genetic studies are important. You should try and first establish the phenotype and then ask for genotypes, gene typing study. in LQT1, it's a little better, the best correlation that even if your phenotype is not strong and you get one of these genes positive, you can consider that this is the diagnosis. Whereas in other inherited arrhythmia disorders, it is good to establish the phenotype and then ask for the genetic study. Since we are going to have it more easily available and at a much lesser cost than previously, we should be aware of how to use the genetics. Sure, Gupta ji.
I think both of you have done pretty well as far as today's module is concerned. I would like to say that Indian Society of Electrocardiology, in collaboration with USV, started this ECG summit in April 2025, and I'm happy that I was the first speaker for this ECG summit, and I'm also the concluding moderator for the ECG module 12. This is the last module of this series, ECG Summit. And I would like to tell the audience that we are going to start very soon the ECG Summit 2.0, which may kick off in April 2026 only. And I think we have covered practically all the important aspects of ECG during these 12 modules, from beginning from the how the ECG, the sinus rhythm is generated to the complex ECGs with the ECG quiz and the involvement of people on the ECG quiz. So I think I would like to tell Dr. Aparna that I have seen two ladies somewhere around the age of 40 for 45 years who developed polymorphic VT during their children going for 12th exam. And that was, I think, quite a stressful situation. And both had stress-induced ventricular tachycardia. Once that stress got over, they became all right. So, have you come across any such incidences?
Yeah, so sir, this can certainly happen. I mean, we are well aware that adrenergic stimulations can bring on these arrhythmias. So one needs to be watchful. That's why I said that there should be index of suspicion, a good history taking. Just as I outlined that young child, the father had every history. We as clinicians must take good history because certain syncopal spells are situational, adrenergic stimulants. So these are things that to be look out for.
I think in ECG, always history and examination is also pretty important because we have to correlate the ECG with the history and examination. So history taking is very, very important, as mentioned by Dr. Aparna and Dr. Ashish also. So I think that's pretty important to document history and then look for the ECG. There may be subtle findings on the ECG, or you may do certain maneuvers to see, like in Brugada syndrome, if you take a in ECG by doing a provocative test or taking a lead higher, and that can bring out the Brugada syndrome. So these things are very, very important. I think if there are any questions in the chat box which can be put up to the speakers, Dr. Shrikant.
Yes, sir. I'm checking. So,
Because I'm not seeing any questions in the chat box. So
yes, yes.
yeah, so if there are any questions by any of the
No,
audience,
I
we can.
think, yeah, you have covered it nicely, sir. I think so. Most of the question you have already covered, and Dr. Ashish sir also shared his inputs also. As you correctly mentioned, sir, we started this module, and today we completed with the 12th module, and you already highlighted that we are going to start the new ACG Summit 2.0 right from the next month only. So it's a great journey, and I would like to request Satish sir to highlight vote of also. Yeah, Satish ji.
I think another thing we would like to tell that we have said that those participants who have attended more than 6 modules regularly will be given a certificate of participation by the Indian Society of Electrocardiology, and that will be done in collaboration with USV. So at least 6 modules out of the 12 modules, if somebody has attended, will get a certificate.
Thanks.
Thank you, Doctor. And first of all, myself, Sadesh Kumar, supporting team Guardian as a National Business Manager. And it's a great platform of learning to many other physician doctor under the board of ISC and supported by Dr. S.B. Gupta sir, Nabar sir, and Aparna Madam, and Jitendra Makkar sir, and Ketan sir, and entire board, almost 12 modules we are completing today, and close to 700 doctors used to attend every modules regularly, doctor. That is what the number has come out actually. Each and every model there will be around 1,000 doctors, will be attending some most of the weeks, but it will be 700 doctors precisely attending consistently for multiple months. That is what we understood when we taken the data and saw the logins and details actually. So I think it's a great pleasure for the doctors who was attending, delegates who was attending virtually and getting the certificate, and which is a premium institute of Indian Society of Electrocardiology, and that will be a great momentum for them. And this ECG workshop, Jitendra Makasar used to say, it is a evergreen learning actually. So that is how many of the delegates were attending and learning every week under the guidance of S.B. Gupta sir, Nabar sir, Mita sir, and Madam Aparna Madam. And thanks once again from my entire USV for supporting this initiative, and delegates are attending across Pan India, and especially Doctor. We supported by Dr. entire medical team and technical team and marketing team. So all these teams have been supporting them for entire session. And thanks for the entire delegates actually, Doctor, who was attending from on time to hear this session. And especially on a Sunday, very important day and a holiday, and taking a pleasure time of 11:30 to 1 or 1:30 goes. Sometimes it goes up to 2 hours also. And patiently, entire faculties were giving the session, and they used to learn from them. Thanks entire team, and thanks Dr. Srikanth for moderating the entire session for last 12 months also. Thanks technical team, and thanks.
Thank you.
Any support that please do let us know.
I thank Dr. Ashish and Dr. Aparna for today's session. Ashish has been a great support for all the academic programs of Indian Society of Electrocardiology, whether it's ECG master classes, ECG summit, or midterm, or the annual conference. Ashish is always there. So thanks Ashish, and thank Dr. Aparna. I've told before Ashish joined, she's a brain and beauty, combination of brain and beauty. So she, I think the way she teaches ECG is phenomenal. So thanks Aparna. Thank you very much. Thank you Ashish. Thank you USV whole team. Thank you USV whole team for these academic programs. Thank you Srikanth.
Thank you, sir. Thank you, Dr. Srikanth. Thank you, and thank you, Doctor. Thank you, Ganesh. Thank you, sir.
Technical team, we can end the live recording.
Yeah, thank you.